Started. Thank you all for coming. It's good to see the fact that it's raining and that this is in a different building and that it's between terms. This is a nice turnout. And so we're all here today to for the thesis proposal defense of Dr. Ben Sanders, who is one of our National Library of Medicine postdoc fellows, and who's in the Master of Science program. So the process for that is that when people are ready to defend, whether it's a master's thesis or PhD dissertation, they present to the department and also to their committee in attendance, who's here. I'll mention that in a moment. So they get feedback and can proceed on to complete their work, and will hopefully come back anywhere from 6, 12, 24, etc. months, depending whether it's a master's or PhD, and then defend their proposal, hopefully successfully. That will enable them to graduate. So Dr. Sanders is a graduate of the UNC Chapel Hill School of Medicine in 2004. He also earned an MPH degree and then did a residency in pediatrics at University of Rochester. He had a few positions along the way, and also while continuing to work as a primary care pediatrician. In 2018, so a little over a year ago, he joined our program as a postdoc fellow, and he also has some responsibilities in the Department of Pediatrics. And his overall goal is to improve pediatric primary care using informatics, and especially in the screening, referral, evaluation, and treatment of developmental disabilities, including autism. So he will present his, and his committees here, Katie, Joan, Paul, and he will present his proposal, leaving some time for questions for us to ask him further details and even potentially make suggestions in his project. So over to you.
Thank you very much. All right, so any way to know if I did this right, or testing.
Really, it's mainly for the recording and
yeah.
broadcasting. But.
Okay, great. Thank you guys for coming. Really appreciate your show of interest by participating today. So I would like to talk to you guys about the informatics of early intervention referrals. This is my master's thesis proposal, so I won't have tons of cool results for you, but there's a lot to talk about. This is the type of study, would call it a national nested mixed methods study. So first, let's talk about what is early intervention. So I'm going to tear up. This is a painting from painted by my father, who's back here in the back, of our first child, Sky, and we call this First Steps. And I think it's very appropriate for this because it's in the home, and the family context is critical. But early intervention for children who may not walk as early as Sky did, it's really nice to have my family be a part of this. Thank you, guys. Children with developmental disabilities are eligible for programming, government programming that offers things like speech therapy, physical therapy, and it's paid for by tax dollars. And what's really special about early intervention is the evidence that it really works on the literature over time, different settings, different populations, and different time spans of study. It's been shown to not only work quite well, but pay for itself as many as 6 times over. And also, the word early is critical here. The earlier you do it, the better of an effect it has. This is child brain plasticity in action. This is, they're much more, they receive the effects of an intervention much better earlier on. So let's take a look at the sort of the pipeline. How do children move into early intervention? So many of them will interact, hopefully most of them will all of them will interact with their provider in a healthcare setting, or it might be in preschool that they would be identified, and hopefully most of them screened, although we know that not all children receive a validated screening questionnaire. And then of those, some of them will be determined to be not at risk. Let's see if this is working. And some will be determined to be at risk, and not all of them will be referred for lots of different reasons. And some of them get referred directly without screening. And then from there starts the referral process, and it does not always get completed. But for those, what I mean by completion of referral is that they get evaluated by the early intervention staff to determine whether they're eligible for services. And then from there, we have, of the children who completed their evaluation, some of them may not have completed it, but of the ones who completed it, some will qualify for services, some didn't qualify, and there's this middle category in some states where you could be a separate program where you could be monitored. And what I'm interested in, and what, as you'll see, is the referral process, but this area of the chart here is the population of children that I want to affect. These are kids who most likely would benefit from early intervention and haven't. So this is a pretty big problem. Here's the population-wide data. So if you were to estimate, about 13% of children at any one time from 0 to 3 are developmentally delayed. That comes out to 1.2 million children in the United States. 2/3 of them is 800,000, and they do not receive early intervention. Here is, we don't have national data for this, and that's a really critical part of my thesis. But this is a study that studied a cohort of children, and basically sort of how well did some EHR decision support affect this pipeline done in Philadelphia. And you can see here with the 3 different study arms, all of them had significant drops in the number of children as they went from, in the clinic, the delay identified, to not all of them being referred, to not all the referred children actually completing evaluation. Now, in comparison to the previous pipeline diagram I showed you, this is really focusing in on the referral portion of it. The screening would come beforehand, and you would lose some children in that part of the process. And then, whether or not a family actually attended services for which they were eligible would also be a part of that pipeline and a part of this number. So this 800 million children is sort of an aggregation of all of the steps. So it's not only a sizable problem, but it's a morally reprehensible problem. Our society's most vulnerable children studies have shown they're the ones who respond the best, respond the most, may benefit the most from early intervention, and they're actually the least likely to receive services. Not just a few studies show this. So I think we can do better. I think services integration, including data integration, is an important part of solutions for improvement here. And just for humor, this is I wore a cape on the day that we went live from paper to NextGen in 2011. So somehow somebody, for some reason, had a cape that said Super Ben on it. So, okay, so back to the pipeline. Here are the steps that we talked about. And I want to point out a pattern here. The left side portion, most of this occurs in the healthcare setting. And On the right side, most of this in most states occur within the educational setting or sector. So that makes this transfer even more important than some of the others in this diagram, in my view. It's a cross-sector transition. So let's take a closer look at that transition, including, let's ask ourselves, let me talk to you about why early intervention referrals are often not completed. Briefly, the referral is made, the parent might call themselves, or in many cases, most cases, a physician would make the decision with the parent. They would decide together, this is what they should do, is see if early intervention would be, if the child would be eligible. And that information might get sent, often by fax, sometimes by phone, and in some cases even electronic. The intake coordinator at the early intervention agency would coordinate this initial evaluation, often done in the home. It's sometimes done at a local early intervention center. And the referral might not, the evaluation might not actually get completed. And so in that sense, the referral would not have the intended effect. And if it is, the child, as you saw in the diagram, it would be, the child would be eligible or ineligible, or maybe qualify for this middle monitoring list. This is, the reasons for it not working so well are quite complex. I don't want to focus, dwell on the details. I'm going to present a number of them, but my main point being that there's complexity and there's a few important portions of it. So we're going to look at 5 different sections. So family and cultural factors is really important. We have evidence population-wide and qualitative evidence to illustrate how families that have less education, who are living in poverty and less literacy, have much less ability to advocate for their child, which turns out to be necessary, unfortunately. If you're a single parent, you're less likely to have a successful referral. If you are Black or any other sort of group that is underrepresented, you would also be less likely to receive services or have I should say, a successful referral. So, and then on the community level, this can look like things like lack of safety. We actually have studies to show us that there are direct effects on things like executive function of a family or the health of a child if the neighborhood's not safe. And right along with that, things like resource insecurity, housing instability, those can kind of add up to create a sort of a chaos and disorganization that really get in the way of participating in a referral. There's also a poor understanding of early intervention and even child development on the part of referral sources, including pediatricians. Some even have a more pessimistic view that if they refer their patient, the patient actually might not benefit, either not get services or get services that were not helpful. And then on a systems level, we have siloed agencies, and so that means siloed data. It also means it's difficult for a family to navigate between those, and it's difficult for other folks who want to know what happened to communicate with all the different players. Just like public education, but worse so, early intervention is chronically underfunded. It's pretty famous for that. It's true across the country. And I think part of that is probably because there's not a lot of folks know what early intervention is or really understand child development well enough to for it to inform policy, say a policymaker or a voter. But that affects the family's understanding also. And then when you get down to the folks who actually deliver these services, they have high caseloads. They have lower salaries than they could get if they were to work here at OHSU, for example. And there's a lot of burnout and turnover. So let's get down to more specifics here with informatics. I want to start with a quote This is the pediatrician I spoke to last year. I would like a closed loop communication system with early intervention. Often we don't get feedback about our referrals. If there was a miscommunication or other problem, I might not find out until, say, 6 months later when they come in again, unless the family is concerned and calls me. I can't remember getting a report from early intervention about a referral I sent unless it was brought in to me by parents. This is quite common. So, what approaches and what things does health informatics have to offer to this problem? I think we can agree computers are an essential tool going forward, not just in healthcare, but keeping track with any data. But human communication is really the core activity that we're talking about here with a referral. And I think informaticians are good at not forgetting the human component of this. Also, the data is fragmented, as we mentioned, and I think informatics is used to dealing with fragmentation with its multidisciplinary approach and dealing with cross-sector problems. This is a complicated problem, and it's also hard to know whether something works in that complex environment. And I think health informatics has a track record of dealing with those problems also with frameworks. So, what parts of this can informatics affect? Well, this may be the more obvious one that you could see I'm headed towards, is that if you were to integrate data between institutions, they would be less disconnected. It would be easier for you to sit in your one agency, say the clinic, and be able to find out easily through the computer what happened with your child's referral. However, you're not going. Data integration is not going to affect housing instability and high caseloads. So what are some other directions? I think a more proximal sort of direct effect it can have is enabling something like tracking referrals. So this is becoming a bigger priority on the part of the Oregon government as we've gotten better at screening, and now it's time to really figure out what happened with our kids as we refer them. But tracking, there's some evidence to show that that clinics who've been able to generate a tracking program have had much higher rates of referral completion. And then I think probably the most important effect here that informatics solutions, such as data integration, and I'll get more specific later, is an indirect effect that really sort of enables other activities. So if the data is integrated, then all of a sudden you can answer questions like, how many children were referred? We don't have that data now. You can't say nationally or even on the state level in many cases. How many children were even referred to begin with? And then how many of those referrals were successful? You can't answer that, and you would be able to answer that type of question with data integration. And so I think that there would be a ground-up effect from interventions like this. Another level of effect would be, for example, being able to evaluate a program or an intervention designed to improve referral rates or other parts of the pipeline. You'd be able to answer the question, well, did it work? You can't do that now. Okay, for my research, I think that making solutions is all fine and good, but it's hard to know what to solve with such a complex problem, and it's hard to. Sometimes it's a mistake to even assume you can come up with the right solution without doing your background research. So for my thesis, I'm doing sort of a start of a career trajectory, hopefully, to start with describing what actually occurs. So more specifically, what data is sent, who sends it, and who receives it, how is it sent, what other important communication occurs in this process, not just the stuff that's on paper or not just the official information. And then what quality, how how can we track the quality of this process? Are these referrals effective? Are they timely? Are they family-centered? Are they efficient? Are they equitable? I think we can assume they're safe, so I'm going to leave out that 6th quality aim. And then to go along with that, what are some barriers? What are the barriers around that? Okay, so let's go back to our model for a minute. I want to show you a little bit about data that we actually do have around. First, let's go to referral sources. I have some Oregon data for that. The primary sources of early intervention referrals in Oregon is from the healthcare setting. A distant second is parents and family, and there's a smattering of other agencies and sectors that contribute. So back to the model again for reference. What is the agency? There's variation between states about which agency actually delivers the program of early intervention. So we do have some national data on this. This pie graph gives you the number these are the number of states, including DC and Puerto Rico. That's why it'll add up to 52, that use a certain type of agency to deliver early intervention. So the largest group, 18 states, deliver early intervention within their health agency. So that would be defined as an agency that actually delivers health care, such as a public health clinic or a state-funded, say, HIV treatment program. That kind of agency is the majority of the cases. Education, including like kindergarten through 12th grade, that sort of part of the state government would be the case that they deliver early intervention in 12 states. Human services, which is things like, it could include public health, like the inspectors of the restaurants and disease surveillance and things like that, not directly healthcare, would be this other category. And then some of the smaller ones, for example, there are a few states that have agencies that are a little more focused on early learning or disabilities. So that's some national data about that part. Let's look for a minute at what proportion of children actually receive early intervention services. And I should qualify here, I should have done it at the beginning, that these are not exact proportions. These are, this graph is not to scale. So how many children do states enroll? This is a histogram, and it's so the rough proportion of children that have developmental delays is around 13%. So you can see the 10 here. So of children 0 to 3 years of age, there's about this many children in the census population on average. And these are the actual averages of the individual states in terms of what proportion of children they actually treat with early intervention. So everywhere from some states have as little as 0.8% of their children 0 to 3 are enrolled in early intervention, and on up to as high as 10%, with sort of a prevalence of right around 2.5%. So who are these states? What does this look like? We could look at the upper and lower 20% just for an example. There's a pretty heterogeneous distribution, except there's some clustering around the Northeast for the upper proportions of enrollment, and some clustering around the Southeast in the lower. But we also have evidence about what are some of the determinants of enrollment rate. So the states, individual states, have the leeway to define what they mean by developmental delay. It could be very narrow, or they could have a sort of a liberal definition, and how wide or narrow their definition is affects the amount of enrollment quite a bit. So a state with narrow criteria, a child living in that state at 0 to 3 would be 70% less likely to be enrolled. Which agency the state uses to deliver the early intervention has an effect. Health agencies tend to do better. And then there's the at-risk criteria. You can, some children receive services because they are at risk of having developmental delay, even if they haven't had one documented yet. And so for the states that do that, you also increase enrollment. Interestingly, where the referral comes from appears to be a neutral factor on rates of enrollment. And I think that what that tells us is more that the way we do things now, no matter where the enrollment comes from, is not working very well. Not that referrals are not worth focusing on. And then let's look at some demographic factors. So poverty has a really strong effect. So as a proxy for poverty being on public insurance, you're less likely to be enrolled. You're also less likely to be to get evaluated on time if you're poor. And this would make sense. Children with more severe delays, they get identified earlier. They get more likely to be enrolled in services. Communities of color, English as a second language, communities in poverty, these folks are consistently under-enrolled across many studies, many states, and so there's quite a disparity there. Again, interestingly, the fact that the rates of physician screening in a state don't seem to have a big effect on enrollment. So if we were to study this and get more information from an informatics lens, where would we start? So these are the main people who are sort of directly involved in early intervention referrals: the child who gets referred and their family, the early intervention staff who receive the referral, the referral sources, and then government, as in the state agency that delivers it or the federal government that does a lot of the funding. And for my thesis, I'm focusing on one of these sectors. The contact information for government agencies across the nation is easily available, and getting in contact with a national representative sample of family medicine providers and pediatricians is much more difficult. So here are my research goals and aims. As we saw before, let's operationalize this. So first, I'm collecting and studying early intervention referral forms. Much of it's done by fax, and that provides a neat thing to sample. And that will address some parts of these goals and aims, as you see here. Then a survey of early intervention leadership. I'm going to invite representatives from all 50 states, and mainly getting at this first bullet point in the aims there. And then what I would call an explanatory qualitative interview with respondents who respond. So, and that will get to some of the why of the data. And then these findings will inform development of the study design for future phases. Okay, so back to the first approach. Let's take a look at some of the forms. So I've done, if you saw my poster this year, this is some of the work that I presented then. This is an example of the American Academy of Pediatrics standardized form, and here's a sort of way you can kind of divide up the data in different categories. As I was saying before, I think this is a really good, convenient way to study this type of interaction, at least as it exists now. I've collected 8 forms so far from 7 different states and the AAP. I found 146 unique fields in these 6 categories. But it turns out that all of the forms together, only 62 of those fields really encompass all, let's say, 80% of all the data fields on the forms. So if we were to look at an example of that, here's 3 different example categories: the demographics, reason for referral, and release of information. These would be the categories most often used, or at least in the upper 80% of cases across that sample we have so far. And on the other side, this is just, you can see a little bit about the distribution of number of fields for the different categories. So this is a brief example of starting the process of examining these referral forms. And the results for this will inform the later phases, especially some of the potential solutions. Okay, let's go to the survey. 50 states and the District of Columbia. I'm going to survey. So their contact information is available through their Early Childhood Technical Assistance Center. We have Qualtrics here that I can administer the survey on as a platform. And if I'm getting poor response, I can resort to snail mail. And I'll be doing reminders by phone and email. My goal response rate is 45 questionnaires. I'd like to represent approximately 60% of states with an average of 1.5 questionnaires per state. There might be more than one per state because when I reach out to these contacts, I'm going to ask them who would be the best person to answer some of these questions, because some of them are a little more technical. And so I may get more than one informant for each state. But regardless, I'm going to focus on representing these 4 variables. It's important, I think, to represent the range of different lead agencies across the states, a range of the eligibility criteria, the range of racial and ethnic diversity represented by the states that I've sampled, and then the actual referral methods. A few states do have electronic referrals in place, and I would want to make sure that that was in the sample, for example, or say website. The survey now, as it stands, has 20 questions. There's 12 multiple choice ranking or estimated percentile type questions. I'll give you some examples. There's a comment section, some short answer, and questions at the end to ask if they're willing to participate in interviews. Here's an example about referral sources. Who sends referrals to early intervention most often in your state? The questionnaire is still a draft, but this is kind of an example of where I'm headed. I tried to combine the question of who sends it with sort of the proportions. Hopefully that will be achievable. They can kind of rank these in a way that we get 100% so we can get an idea. And then here's another one. What methods for sending referrals are available in your state? And I think I still have some work to do on some of these options to simplify them, but it's an example of kind of what I'm trying to get at. And then so a little bit of follow-up about what referral forms they use. It may be difficult to capture some of the variation within states. Some states have a number of different forms that are used in separate regions within the state. So I may modify this question, but I think it's important to ask it. And then, how much is that referral form used? And then, so after that, for the folks who are willing to talk with me, this would not be exploratory qualitative research. This would be more of the sort of the contrast of towards the explanatory. I'm kind of already imposing a structure on this in terms of wanting to improve referrals with those quality aims, and really I want kind of the why to the what. But it is a qualitative conversation that needs to be had. I can't really do it with a survey. So I want to further explore these perspectives from the state leaders. Here's where some of the interview guide questions will be coming from. I'm going to pilot the interview guide with with Oregon State Early Intervention Leadership. These will be done by telephone, and transcribed. If I'm traveling to meet my family at home in North Carolina, I might do that one in person. And so not only the transcripts, but memos that I write as I'm doing the interview about our conversation will be incorporated into this, and state websites, and then if there are other documents that they have available, like data definitions or policies around this, I would collect and include. And then codebook development. I don't have a big qualitative research team, which would be ideal, but I think it's, from my education, I think it's critical to get multiple investigators' input on doing things like developing the codebook and then also reviewing some of the analysis. This is time-consuming, so I'm hoping to get representation from these different aspects of early intervention referrals between states with as little as 6 to 10, as little representation from as little as 6 to 10 states, and potentially more than one per state, but I think time may ultimately define the limit for that. So I would want to know from them, here's what you put, or here's what your colleagues put on these on the survey that you filled out. Can you tell me more about that? I would want to know things like, what do you think about how the state of things are now? Do you think that it works well? Do you think that it happens in a timely fashion? Are families involved in this process, or is there any sort of state level prioritization of family-centeredness or disparity, addressing disparities? Okay, and then lastly, I'm going to incorporate this into the next phases, which include talking to some of the other sources. But in terms of the analysis of the portions we just went over, we have the referral forms here. I'll have some descriptive analysis of the survey data, but we'll need to use some qualitative techniques for the open-ended questions, and I'm going to develop a priori process for reconciling questionnaires within a state that are discrepant. It might be as simple as calling up the respondents and saying, you disagreed with the other person, what do you really think? And then what we're doing here is sort of describing the phenomenon of referrals, and that would be the type of the qualitative analysis, and so it's not inductive so much as deductive. And then to summarize the information, this would be sort of the academic product here, this last point for the near term. But all along, and I need to be considering the informatics implications. So, answering questions like what is the current state of data? What is the role? What are the roles of current referral methods? And are there other types of information transfer that are critical to this process that if we miss, we're going to create unreasonable solutions? And then I'm anticipating that potential solutions down the road are going to need to address some of these challenges. There's a lot of variation between states and even within states. There's not a lot of money to do this type of stuff. The different parties involved in actually doing the referral have different agendas. And the families and their preferences really need to be kept a high priority. And then later, I want to get the perspectives of other stakeholders, families, providers, referral coordinators, and as I go, integrate these phases together so that eventually I hope to be able to propose data structures, functions, and formats needed to make early intervention referrals better. That is outside of the scope of this year. But speaking of this year, here's a timeline. I tried to simplify it. I don't know if you can read this. Here are the weeks left in the academic year. This is the time I have left. Here's IRB, the survey duration. Here's fall term, interviews, analysis through here, manuscript writing, preparation for defense, and submission of a manuscript to journal, and then the thesis defense. And then on the greater scale, this is just sort of a guess about how I might do this. So here are the other stakeholders and participants in the referral process, and I would reuse some of the methods, but then for these other populations, and overlap some of these analyses, and over time generate a framework using all the information. That's what I got. I want to thank Dr. Paul Gorman, Dr. Katie Zuckerman, Joe Nash for your contributions and support to me. Here's specific faculty that have really contributed that I appreciate. DMICE staff, colleagues who've made specific contributions, other colleagues outside of DMICE here, and some folks outside of OHSU, and especially my family and my partner Dawn here, who has put quite a bit of investment in my being able to generate this work and do my best. I'm funded by the National Library of Medicine. That's it. Worse. 43 minutes. Yeah.
Okay. Do you plan to look at cost or cost effectiveness, or maybe at the different states or different programs have different approaches that are maybe some are more costly than others? Like maybe some have more public health approaches to the problem as opposed to the individual therapies.
You're saying of the state's approach to delivering to receiving referrals. Are you talking about the whole system or just
I guess I'm looking at more of the state of what their programs are, but is that outside of your scope?
It is outside of the scope, but also we have some data about that. Not excellent data, but we have you can make a pretty good argument that overall this is worth doing well because it is very cost effective.
So it was a really interesting talk. I'm just interested in, so with your explanatory qualitative phase, how much communication is there between pediatricians and social workers about like why these referrals kind of like fall flat? Because it seems like that would be another perspective that could be useful.
So I won't be getting down to the sort of clinical level in this phase, unfortunately. I really had hoped to. It came down to access to populations. And it was really important for me to get a national sample. And so as I look at referral sources, I'm definitely going to have the approach of sort of the team of care. And so we'll probably hit on some of the issues like the different roles, not just the physician. Absolutely. Thank you.
You made a point at the end about the kind of between states and within states kind of interactions. And when you chose which states you were going to look at, for your national look, how much do you think there is a lot of crosswalk between the states, like, the northern border of Oregon and the southern border of Washington versus some of this, where you might work in one state but live in another state, or your caregivers, or, where you're dealing with kind of multiple states in your negotiation potentially, whereas maybe some of the other states you're modeling, there really aren't that many kind of border populations, as it was. You get to see both kinds of situations based on where you've chosen your state samples.
Yes and no. So on the ground, it turns out that there's the families that end up having to deal with those types of things because the delivery of these services is based on state organization policies and things like that. So when they actually get to the right place, it would really be specific to, it's based on where they live. So that would be fairly clear from a sort of governmental systems perspective. But unfortunately, we can't ignore the fragmentation, and so families living in such a scenario absolutely would have difficulty with that. And so maybe in further phases, that'll be part of the picture, is how to navigate just where the heck do I go. Does that address your?
Yeah, so I guess I just meant, like, in your states, like in the states you chose, are there states where they're more like lots of people are in the tri-state area living differently than, like, they're providers in, New York City, but they live in New Jersey, but they're, or the Washington, Oregon thing. Like, do you have samples of kind of both kind of states where a lot of people are crossing border, lots of state scenario versus some states where it's really just like that state's mostly dealing with that state,
Right, yeah, and I'm sure if I had that level of information, there probably would be clustering of effects and things like that based on more on population, kind of economic centers instead of governmental structures. But I've kind of committed to a more limited sampling method by going to the state government, at least at this phase.
No, that makes sense. I think I was just trying to picture where your states were on the map.
And I haven't designated them yet, right?
Thank you. That was what I was thinking.
So
I just missed that.
The questionnaire is going to go out to all 50 states and DC, and which ones I get back is the first answer, and then of those, the ones that are willing to do interviews would be the answer for the phase after that.
Perfect. That's what I was trying to understand. Were you sampling intentionally, or was it first? Yeah.
So it is a combination. So I'm glad you bring that up. Is that I'm going to see who I get responses back, and the people that I will pursue the hardest will be the ones that represent the sections that I really would want to have represented.
Perfect. Thank you.
Thank you for your question.
Two questions. One, if you had to go off a hunch right now, what's your hypothesis for what your results might be? If you need to scope it down from there, maybe, what do you think would be the top one or two barriers that come out of this work?
Funding and variation. So I think state organization, agency leaders are going to say, we don't have money for anything. We can't even pay our folks to keep them here long enough. I just got here last month because the last person quit. I think that's going to be one of the major themes, and then and the sort of the profundity of effects that has on institutions getting anything done, and then variation because in some states, California, for example, really they're quite regional. The regional centers that deliver the care actually have most of the decision-making power and how things are done, and it would be really hard to say much that's very useful about a whole state, and I think that'll make it difficult. But in terms, you could call that a result also, is that the variation is so prevalent that it's difficult to talk about the nation.
Or that it matters at below the state level.
Yes.
Second question then was, let's say survey responses come back and you get 5. What do you do at that point? Because your kind of third method relies a lot on that second one. So I'm wondering, what kind of pivot might you be able to do to still get good results or actionable results if the survey doesn't get quite the response you want, even with the follow-up phone calls and all that?
Okay, so short of, like, even beyond hitting the phones.
You've been doing it for a couple months.
Yeah, okay.
Still.
Yeah. I will probably emphasize the referral forms and the inferences I can make from that, because I think I think I can go a good ways in making some conclusions about what's happening. But that is absolutely possible. I don't think I've planned for that at this point.
So what kinds of people are on the mailing list? I'm trying to get a picture of the organizations. Do they have chief information officers, or who do you think will be answering the question?
I do hope to get access to some of the folks who manage data in these states. In this day and age, most states have some, even if it's just one person, they have somebody that deals with the data. And Oregon's is a good bit more complex and has decades of experience, but most states have somebody that at least owns the Excel file in their computer that can talk about this data. So I hope to get to a person like that. And then to a leader that has some experience with what happens on the ground maybe somebody that used to be a referral intake coordinator that kind of rose through the ranks. But in terms of their official title or the titles of the agencies, that's really going to vary quite a bit. And so it's at least through federal funding and federal requirements, there are some standardizations of roles. So there has to be a designated contact person. There has to be an early intervention lead agency. That's sort of a federal term, lead agency leader. So that'll be the people that I'll start with contact. Does that answer the question?
Do you have a plan for how you're going to validate the responses from those who do respond to at least 5 or more do? And I ask this because I've asked questions to people in surveys, which I later discovered they had no idea what the answer to was. And sometimes they answer, what's the population of your catchment area, et cetera. So I wonder how, and in fact, the survey that Joan and I did a long time ago, we asked people if they had position order entry, and we got conflicting answers from within the same organization. By people you think would know. And so, do you have a plan for how you're going to validate the replies, or how you're going to know whether you need to?
That is one of the roles that the that the follow-up interviews will have. If I start to get the sense that we're really going in the wrong direction with a couple of these interviews where I'm incorporating the results of that state-specific survey results and asking about them, then I'm going to have to back up. I'm going to have to back up and what would I do then if they were grossly misunderstood? If a subset of questions were misunderstood, I would probably not be able to use that data for, and hopefully other questions would be well enough understood that I could make something useful conclusions out of it. But if they were all misunderstood, I think I would probably focus mostly on the interviews because I can actually ask people what they think and get a sense of their understanding.
In follow-up to that question, is there not a validation process in place for those items prior to sending out that should hopefully shake out some of that?
Yes, just like I'm going to do the first round of developing the qualitative interview guide with the Oregon state leaders. I'm currently in the process of validating the questionnaire itself with Oregon folks. I've run it across a lot of desks here at OHSU, but I think it's most important to get it in the hands of the people that are closer to the target population to get a sense of how the tone comes across and misunderstandings of terms and things like that. But thank you for bringing that up. That's absolutely a part of the plan. Okay, thank you guys so much for your engagement. Really appreciate it.